All right, this is great. I think we are recording. Yeah, so it is my great pleasure to introduce our guest speaker, Dr. Zara Marselian. She's the CEO and president of La Maestra Health Centers. Zara is not only a friend and a guest speaker in my courses for many years, she's also a client as La Maestra has been using my company's software, Patient Angle, which is the sister product of the what you're familiar with, Class Angle, in La Maestra. And La Maestra has been using Patient Angle to capture patients' feedback as part of their overall um, continuous improvement program. I'm continually amazed by Dr. Marselian's passion and commitment in serving economically disadvantaged communities. Zara, it's great to see you again, and thank you again for taking the time to be with me and my students. Uh, would you please tell us about La Maestra Health Centers and how IT projects have helped you in achieving your mission?
Well, thank you so much, Farhad, for having me again. And I certainly hope that our lessons learned and our journey to where we are now is going to be helpful with your students and give them some ideas of what we've been able to do and how we have built our IT framework to support our model. So let me just start a little background about La Maestra. And we actually started La Maestra Amnesty Center in 1986. We had 12,000 patients, not patients, they were students who were seeking amnesty under the Immigration Reform and Control Act of 1986. We were all ESL teachers, VESL, teaching vocational training, and we were very familiar with many students that could qualify for this amnesty program. So we started off and we taught English as a second language, vocational training, computer literacy, and of course, helping people with their immigration applications, the phase 1, phase 2, so they could gain their residency after many of them, like 20 years that they've been here working. And so as part of that, there's a big trust that develops between the students and the teachers. They would tell us, we don't know where to take our kids for healthcare. We don't know, since we don't have insurance, if we're going to be accepted. Or they tell us about some other situation, domestic violence or a lack of childcare, or they had children with disabilities. They didn't know where those resources were. And that just led us to look and see what we could do in response to their needs. And through the student council, met every month, they would ask, hey, can you just add on some medical services? So we thought, well, that can't be too hard. And we were a bit naive, obviously, but we did. I mean, I searched, I looked at other health centers, I talked to hospitals, I talked to the county, public health. And so we started La Maestra Community Health Centers. It was called Family Clinic back then. Under the amnesty program in 1990. And then in 1991, I sought a totally different corporation for the health center. So here you can see the first clinic. It opened, it was, small house residence that had been built in 1920. So you can imagine bringing things up to code and getting licensed by the state. Well, that was a big experience. And subsequently, as we expanded, we then were able to lease the buildings adjacent to, the first structure. And again, same issues, old buildings. It was really challenging. We were then able to build a brand new gold LEED certified health center down the street, and we moved there in 2010. And we thought, wow, we're going to have how much room in this 36,440 square feet that we had designed, environmentally sustainable building. And, we were there 2 years, and I had to move all of the admin back down the street in these old buildings that, are very charming, and they allowed us to grow. We had 80,000 patient visits when we were able to move to this brand new building in City Heights. And, since then, we've just continued to grow, and I'll talk about the sites and everything. But I wanted to give this background because we did not start off as a health center. We started off as educational center that added on a lot of social determinants. Immigration service assistance was one, obviously with the amnesty, which led to citizenship assistance, political asylum visas, or applications, and then the human trafficking visas, victims of violent crime visas, and on and on. So this gives you an idea of our La Maestra Circle of Care holistic model, integrating what we have found to be the social determinants needs of our vulnerable populations. And we'll talk about who those populations are. But you can see from here, we came up with this image because we could then, group all of the medical services. They're very comprehensive: primary care, specialty care. You see like the specialty clinics, diabetes clinic, hypertension clinic, asthma remediation, liver clinic, senior centers of excellence, and on and on. And then on the, then you get to dental and mental health, behavioral health, imaging. A lot of federally qualified health centers, such as La Maestra, do not have this level of comprehensive services under one roof. Now, the other petals you see there back on the circle of care represent the way that we define, and others do too, many federal agencies, the other social determinants that have a lot of impact on somebody's well-being. It's not just a trip to the doctor. That's awesome. That's great. Taking care of the health, being preventive, and so forth. But, the housing is a big issue, food scarcity, and so on. So you'll see here, we are a super pantry, food pantry. We have a community garden. We have a microcredit program for economic development, housing. We do transitional housing. And then we have a lot of supportive services as well, youth development, and all of the enabling services: transportation, translation, advanced case management, and so forth. So you can see from the groupings here the different services that we offer, and why then our IT framework has to fit and capture all of these services, right? And the flow of the patients, and making sure that they are being referred for services that they've identified they need across the continuum of care. Next slide, please. Great. So this is, we have now 22 licensed sites across San Diego County, and mostly our headquarters is in City Heights. We also have various clinics out in East County, which is El Cajon City, National City, Lemon Grove. We have licensed coaches, mobile clinics that go to other areas outside San Diego, to other counties as well. And, it's amazing. We have school-based clinics also. And we are the only federally qualified health center here that offers mobile mammography. And that's a big deal. Our number of patients, you can see, has really grown from our original 80,000 back in 2010. During COVID, of course, it took a dip, but we actually were able to not shutter any of our sites, and we continued offering services in a very safe manner. We did transition a lot more to e-health, telehealth, that we'll talk about in a minute. So just about what last year we saw, I believe, was 175,000 patients and patient visits, and then the unduplicated patients was about 42,000, something like that. So that just counts the medical billable encounters, doesn't encompass any of the visits that we have with clients that are not yet patients, that access all of these social determinants services. So now I wanted to just mention, who do we serve? This graphic was done through the research part of my doctoral studies. And I looked into, obviously, our records and the data to see which, like, what commonalities do our patients have? What are the challenges? And this is what I came up with. All of our patients, maybe 98%, are low income. That's the first big point. Poor is poor. And it really does then lend itself to more challenges and barriers because people have a lower social economic status. They don't have access to resources. They can't choose which kind of medical plan they want. They're limited. So if you look at the vulnerable populations, you see children, immigrants, refugees, homeless, re-entry, all the justice-involved population, those that are victims, elderly, veterans, chronically ill, and those with substance use disorder. So that's one group, and then you add the adverse social determinants that they experience, which you can see here, the health disparities, lack of healthcare services, versus if they had a commercial plan, let's say, that they could afford the copays and they could afford the medications and so forth. Lack of safe and affordable housing, inefficient economic development, they don't know what their resources are, food deserts, and so forth. Then you add to that the prior life adverse experiences that many of the patients experience, whether refugees, immigrants, the migrants everybody hears about coming across the border, the trauma that they've experienced as well. So you can see here, it is compounded, overlaid challenges that people face. And so that's what we are dealing with when we are providing these services. Usually patients or clients, when they come in for one of the services that you've seen on the circle of care, they will be needing at least 4 or 5 others for them to, achieve some level of well-being and move on and then address the next set that come along. Next slide, please. So La Maestra is one of the most culturally diverse health centers. We've heard this from, our regulatory agencies, our funding agencies, the feds, the state, and so forth. Our sites are along the U.S.-Mexican border, and we are a refugee resettlement agency as well. So the staff represent the cultures that we serve. This has been intentional from the beginning. We knew that communication is key. You have to be able to communicate with the patients or clients and understand them from their perspective. How does their culture play into it? How does their religion play into it? And it's all about meeting people where they are and where their needs are, and then helping them from there and engaging them to be part of their healing process. And you can't do that if you can't communicate with them, basically. So right now we are up to 60 languages and dialects through our health centers, and our staff are representative of those groups. So we, from the beginning, established a very innovative model that has served us well up until today. It's a medically trained cultural liaison program. So let's say when the Sudanese were coming to San Diego, we spoke with their community, their elders. We identified people from their community that perhaps had worked in the refugee camps with the United Nations programs for the health and so forth, and had some medical training. And from there, we employed them and provided them additional training. So they have medical training, some medical background. They understand what are the risk factors, the urgency for people getting into the services they need. They understand the culture because they're from the culture. They live in the same housing units, areas of the city that our patients do. So they fully understand the complex needs that the populations face. And so they're able to then educate our providers and our other staff about the culture and how what barriers to compliance with medication or different treatment modalities, or what their beliefs are, so that we would know then how to deliver the message of health education and so forth. So that just shows you, gives you a brief indication of some of the innovative programs we've created throughout the years, and how we then utilize the staff and how they utilize the IT. So anyway, we've covered some of these challenges. I just wanted to mention, that our populations have greater economic challenges, issues with housing. Public housing wait list here in San Diego is 13 years. So what does that mean? That means that there's some affordable housing available. Well, affordable really isn't affordable if you get into a subsidized apartment unit and you're still paying $2,000, $2,300 a month, and you're a single mom with 3 kids. It's not affordable. So what does that mean? That means that families tend to group in apartments. So you'll have multiple families living in small spaces that are usually old, rundown apartments in high crime areas. How does that affect health? Well, if you don't know that they're living in these cramped quarters with no ventilation or very little ventilation, and the child keeps coming in for asthma, that's something that the provider needs to know. So those are, all questions that we have added into our electronic health record, and capturing that information around, where does the patient live? Are they living in their car? Are they homeless? What are some of the other issues? So that's really, really impactful on being able to help patients, instead of just giving them more medication when their issue is that, their AC or the fan doesn't work, and they have a carpet that's 30 years old. The landlord doesn't want to change it. They're afraid to say anything because they're going to have their rent increase even more. All of those are considerations. So they also have lower preventative screening, especially if they're coming from other countries. You can imagine these migrants that have been walking for 9 months, 6 months. They haven't had a lot of preventative care, especially the prenatals. It's really difficult. Limited English proficiency. We've recently had in California and in the United States Medicaid re-enrollment. So this has posed a huge problem. Back in, I would say, April of 2023, many states started this re-enrollment process after COVID. And there were originally, in March of 23, there were 94 million Medicaid recipients. And now, as of March 2024, they've lost almost 20% of people that were on Medicaid because they didn't fill out their packets, they didn't get their packets, they didn't know or understand because it's only in English. And so this has been a huge issue. People think they still have coverage. They come into healthcare services and they find, well, wait a minute, your Medicaid, your Medi-Cal, or your Medicaid card is not valid. You have no coverage. 37.5% of people who've lost their Medicaid are children. And they have 34.4 million renewals that are waiting approval by Medicaid. And it just shows the amount of work that health centers and other healthcare providers have to really invest to make sure to educate their patients, help them with their reapplications, so they can even access the care. So that has been a huge issue for all of us. Another one is, inadequate public transportation systems here in San Diego, environmental health impacts in San Diego and elsewhere. We have excessive heat, the wildfires, so forth. Immigration status changes, deportation proceedings. This is very impactful in a negative way on people that have anxiety, depression. They don't know what their future is going to be because immigration hasn't processed their applications or they have issues with that. And they don't really have the resources at hand to know, gee, how can I go to school? Where can I go? I have a degree in my country, but how is that going to translate over here? What certifications could I get that would get me into a job that pays me more? So all of those are considerations and part of the social determinants that we have tried to address. Next slide, please. Through this trajectory that we put together for our vulnerable patient populations, the idea being that La Maestra is their integrated medical health care with social determinants. We're their medical home. Through us, they can obtain additional resources to address their social determinants needs, whether it's through La Maestra or through one of our extensive network partners that we have. In any case, they are able to access those resources and hopefully achieve more health equity and well-being. Next slide. So that brings us to how we can look at our IT framework and how it has grown along with our services. It mirrors the patient pathways. Our biggest issue when we started to try to integrate our social determinants into our EHR, which we use as NextGen, EHRs were primarily focused on capturing the data of your patients. Well, what if somebody isn't a patient yet because they've come in through our human trafficking assistance program? And yes, they will be referred over, they will become a patient, but how do you capture that data up until then? And so for all of our social determinant services, this was the issue. So we started off years ago trying to have them capture the data on disparate systems, right? Or creating our own data management system. But what happens then is that the providers, when somebody ends up being a patient, doesn't have access to all of the other services that that patient sitting in front of them has already accessed. So the provider won't know, gee, this patient came and was referred to the clinic through La Maestra's human trafficking assistance or immigration services or youth program or whatever. And they won't have the data already there of what services they've been provided or where they are or what their issues are. So so the providers didn't want to take time to get off the EHR, open another system, log in information there or view it, and then come back to the EHR. So long story short here, this has been a long journey for us. We were finally able to purchase an additional practice through NextGen that would capture that social determinants of health, history, data, programs that they're attending, the plans, how were we able to help them? And so it is just a drop-down menu on the screen So the doctor just clicks that screen and right away they see all of the social determinant services that we provided, or those that they could refer the patient to that they haven't accessed yet. Maybe it's the food pantry. We don't know. So this required us to custom build a lot of our templates and mirroring the way that patients and clients utilize the services across the sectors. So it's not just healthcare, it's across the sectors of housing and economic development and so forth. And a challenge for us has always been, gee, how do we demonstrate the value of our circle of care model? Like, what difference does it make? How can we show that it brings value-based healthcare to our patients? And yes, we can show, gee, these patients access the emergency room 9 times last month. And now that they're with us and they're accessing all of these services, they haven't hit the ER in 6 months. That's a value, sure. But it's very complicated for us to show, okay, so let's say our patients with diabetes, their A1Cs are much better now. Okay, is that simply because they had access to the provider, or was it, and they had their medications and they're being compliant and so forth? Or was it also because they access the food pantry and they have health education and they're growing their own food in our community garden? I mean, what is that value? And so that's something that we're always looking for, that return on investment that we can show our funders and managed care plans about the value, demonstrating the value and being able to basically to say, okay, this is because of the integrated model that they have these resources and they are accessing them, because we can see that it's all tracked and captured and analyzed and reports and so forth. So that's something that we are continuing to work through. And then, of course, our telehealth, e-health, patient portals, and the lessons learned, one of them was that I basically shared. We can't have providers using different systems. They don't have time. They're not going to get off one system, get on the other, then get back. So everything had to be integrated in our EHR, and we've accomplished that, thankfully. Next slide. So we have our electronic health records. I spoke a little bit about that. We have the ability to incorporate and track non-medical social determinants of health services for both internal and external referrals for patients and clients. Because the big issue was, if somebody's a client but they're not yet a patient, we could not before add them into our EHR because they weren't a patient. So thankfully, that's all done. The quality improvement chronic disease management is an I2I program that interfaces with NextGen. And then, of course, for customer service, we have our patient angle that Farhad spoke about, and that really has been very helpful. It captures real-time patient satisfaction. If they are limited English proficient, that doesn't matter, because the pictures of the staff are there for them to choose on these laptops or kiosks, and then they can, put their level of satisfaction with the visit. Then, if there is like 3% satisfaction or less, that result immediately goes to the supervisor of that unit, so we can deal with the issues right then. We don't have to wait 6 months later when you get results from some surveys. The other how technologies helped us with customer service is Well app, which now we're moving to Frisia. That's the text messages that patients get, after their visit. How was your visit? Did you feel that the provider listened to you? Were you part of your patient treatment program? Did you feel like you were engaged? Did you understand? All of that. That's very helpful. And that automatically goes out to the patients. The surveys then that we participate with our local coalition, statewide coalition, that are sent, through a third party, that's also a way for us to capture the customer service and how we can continuously improve our process. The telehealth and the mobile clinics, we use Auto, WebEx, Zoom for virtual visits. And after COVID, a lot of our patients with mental health or with substance use disorder, a lot of them really prefer telehealth services. And so we have obviously the clinics, right, and the inpatient care, but this is a good support to be able to, again, accommodate people. Then we use the wide area network. We use digital imaging for like our mobile mammography coach. We have a 3D tomography and we use DR for that. That allows us to have the images immediately available back for our radiologists to read if we're out there in the field and we need to refer the women for secondary screenings. If they see any abnormalities, they can act upon it, real time. Then we have immunization registries. The county requires us to share this information, and that gets us to the health information exchanges. We have a regional and hospital specific HIE, and that's through our San Diego Health Connect. And that connects now to the state of California, which is the California DXF. San Diego has tried for the longest time to have our own HIE program system, and it's been failure after failure. So now the state is basically in charge of it, and the counties then will push that information up at the state level. But to date, we're able to participate in this HIE just to push data over for immunizations or other data that the county or state is requiring. We can't go on there and see anybody else's or find more information out about a patient yet. So that's kind of been frustrating, but we're all working on that. We also have remote patient monitoring for patients with chronic disease and to support those patients in our home health program, where we go into their homes if they have chronic disease, they're elderly. So this has been really fascinating. We started off with blood pressure cuffs and with the Dexcom, the diabetes monitoring through some small grants, and it really has been very effective. We're trying to expand that much more. And we have our La Maestra patient portal. We have a La Maestra app that they can download, put on their phone, and through that, they can access the portal, they can make appointments, they can see their lab results, they can get a copy of their vaccine cards, a lot of good pathways there for the patients. They can download the new forms every year they have to fill out, re-register. And of course, our social media is very helpful. Next slide. So the telehealth specialties, that started with us in 2012, 2013, where we saw a lot of specialists that we'd been referring our patients to that participated in Medicaid, Medicare. They said, look, it's a pain. It takes us 3 months to get reimbursed through these, federally subsidized programs. And there were usually a specialist like up north in La Jolla and other places, very difficult for our patients to travel. So we said, okay, look, how about you stay in your offices in La Jolla and elsewhere? We will keep the patients at our site, and they can then tap in through telehealth. And, for this, 15-minute visit with you, Mr. Specialist, and our primary care provider is in the room, explains everything. We do all of the translation. We provide all of the background, the history, and what's happening with the patient. It's awesome. We have the translators there. That worked really well in being able to keep and engage very expert specialists for our populations instead of cutting these wonderful resources and these specialists just wanting to deal with commercial insurance because the rates are higher. and their populations don't tend to have as many challenges and complexities as our special populations do, or Medicaid, Medicare. And then the other way that we use this was also in-house. And of course, I'd like to add here, to the ear, nose, and throat, internal medicine, gastroenterology, and many other of these areas for specialty. And we had these telehealth carts, we called them. So we had the scopes and the lenses, and we could do a lot from our site. So then we got to, well, okay, well, now we have many more sites. We don't have all of our specialists that are in La Maestra, let's say internal medicine, geriatrics, and so forth. We don't have them at each one of our sites. How can we really utilize them and let them stay where they are? Let's say they're in El Cajon, or they're, in National City. And let's say in City Heights, we have a need for that patient there in City Heights to have access to that specialty. So we then provided the telehealth, and it was awesome. And we continued to do that. And that really helped us prepare for COVID. Not that we knew COVID was coming, but it positioned us well, because we already had we'd worked out a lot of the issues with these different systems that are all working together. And, it was just so much easier for us to immediately, I think it took us like, when COVID hit, maybe, within 2 weeks, everything was remote, up and going as much as possible. And again, we didn't have to shutter any of our sites, and we kept everybody safe and complied with every regulation, and kept that access open, which was very important, not just for the services, but for information and so forth. So then, again, the remote patient monitoring, that was really exciting. We continue to see now that CMS is going to reimburse for different parts of this remote patient monitoring. Before, for FQHCs, federally qualified health centers, such as La Maestra, we could only bill for part of it. We couldn't bill for the monitoring part. So that is another function that we can either contract out for. Let's say you have this constant monitoring for the blood pressure. There's a nurse always reading these results as they're coming in. If there's an issue, she immediately contacts the patient and the provider and so forth. It's very beneficial, and the pilots that we've run on these is really very good. The issue was being able to be sustainable with this program, because as I said, only parts of this were reimbursed. So then the next slide, please. So this is our reporting, our SSRS SQL Server, our next gen, and our practice management system for the chronic disease population health. We have the imaging interface, lab interface, e-prescribing. All of those generate reports. And we wanted more proactive, streamlined approaches to improving access by looking at, how well are we doing with productivity, for example, the case management. How can we track the issues that the patients or, the health plans are experiencing? How do we make sure we don't lose people, drop them somewhere down the system? Could be, maybe they didn't follow up with a referred visit, or they didn't get the prior approval, authorization from the health plan. And so the patient kind of gave up. They didn't know what to do. How do we know that that patient didn't move forward with that? And what were the reasons, and how can we work around it? And this is what these reports and functions help us to do. So the better case management, analyzing tools, productivity reports for each department, each site. Then how does that tie into the financials and our grant reporting obligations? Then also for predictive analytics, we're able to it was an incredible study on the importance of medication adherence with our diabetics. This was really a eye-opening experience because we were able to pull the data and information from La Maestra, but then getting it from the managed care plan to see how many times did these patients access the emergency room because their A1Cs were out of control or they were in a diabetic coma. What happened? So for us to be able to really analyze that requires that data coming from all providers in La Maestra, outside of La Maestra, to really get an idea of what suggestions and solutions can we come up with to prevent the patients from getting into that crisis mode. Well, this report took us a long time, and we basically came up with some good solutions for the health plans to authorize refills, not just, every, 30 days, but give them enough for a 2-month supply, especially if people are being dropped off of their coverage. And that really seemed to help. We're identifying other ways to mitigate some of these challenges, especially now that San Diego County, as of January, went from 7 managed care health plans down to 3. So you could imagine the confusion that added 2 patients that needed to transfer, move, or be defaulted onto another health plan with yet different requirements and pre-authorization pathways. So these reports really do help us try to figure this out. So then comes artificial intelligence, AI. This is really fascinating. We have been looking into how AI can help us with our, with everything we do and enhance the workflows, but yet not put patients at risk. So for example, one of the other clinics already incorporated AI into reading their dental x-rays for their patients. What they found was that the dentist then just relied on the system to identify issues and what their future problems could be with their oral health based on those x-rays. And the dentist ceased to look at the x-rays themselves. So that brought issues into, that they hadn't anticipated. Now they have policies that no, you can only use this AI as a double set of eyes and you can't rely on it entirely. So that was a good lesson learned. And then how do you improve real-time data analysis, identify utilization trends, patterns of how they utilize the care, and then how can we continuously improve the process? We can use AI for that. Productivity, definitely. Our predictive analytics, yes. Reporting functions, like I mentioned, utilization, productivity, financial, so forth. That can all give us single data analysis. AI is great for that, but then it can't provide the whys, like why is this happening, or figuring out the solutions. That requires obviously humans to be looking at that and talking about it. But AI, I mean, the opportunities are limitless. It's just, we need to make sure we're being vigilant and thinking about how we're going to be using it. Right now we have staff that all they do is they analyze the productivity that's then reviewed by each site, each medical director, the providers, the staff. That's something that definitely, can move more to AI. And then the use of AI in, IT security, strengthening and securing our network, preventing stalling cyber attacks. We've had coalitions here in San Diego that have been, had cyber attacks, ransom, demands and so forth, and hospitals as well. I mean, I'm sure everybody's seen it across the nation. So the more we can do to prevent all of that, the better. Now, how else are we using, well, AI for one, with the digital mammography, the 3T tomography, it's so clear. It's like reading books, pages in a book. when you're looking at the results of the mammograms. Again, the system we use already had incorporated since 2012 those second pairs of eyes. So if a radiologist misses something, the system will pick it up. Again, it's a great tool to have. These are some of the other IT systems that support our imaging. And next slide. So like, what indication do we have that all of this works, that it improves? These are the HEDIS measures, health outcome measures, that we are graded on as federally qualified health centers by HRSA, the Bureau, many different agencies. And these are some of the badges that we have been awarded because our scores are good. They're good. We continue to improve. Next slide. Here's another one for quality of patient care through NCQA. And that's super important for our own feedback, but also because we have embarked on a lot of residency programs for dental, for mental health, marriage and family therapy, family practice, and so forth. And it's really important for us to maintain, and because we want to anyway, the quality of services and the value we bring to the patients and to the community. Next slide. And this is another one through our cardio clinic, specialty clinic. We also have received from liver and our liver clinic and so forth. It's just HIV as well. It's amazing. And the more we can incorporate technology into our systems to mirror the integrated model and the pathways people take to access numerous services across the service sectors, will really enhance not only their well-being, but for us to be able to prove that this model works. Models that integrate and capture all of the other well-being factors are super important. It's not just a trip to the doctor. Thank you so much. That concludes my presentation. And
Zara, thank you so much for sharing how Maestra kind of giving us the big picture of where you started and where you are. But this is truly an exemplary organization in terms of using technology in achieving your mission. As I listen to you and I see how you establish that integrated IT system to provide an integrated picture to your providers so that they see everything that is been done for the patient, and also the integrated picture that it provides to the leadership and management from all aspects of the organization in terms of medical as well as financials and the like. Furthermore, I think La Maestra continues to be an organization to show how you can take advantage of new technology and bringing that to your technology, your example of telehealth, of how you started back in 2012, which is when really most people had not heard about that. And even for many more years, they did not embrace the technology, and how having that technology implemented in your organization, you were able to deal with COVID so much more effectively. And now, of course, as you covered, using AI for many things that can streamline, can really do many tedious tasks that would free up your staff. I would like to actually wrap this up by posing a question to you, Zara, as our graduate students are going to be leaving school and going to the work environment. I would be interested to hear from your perspective, the challenges that you see for an organization like La Maestra that you are going to be facing in the next 5 years. And these challenges perhaps would be the area that the students can focus on and help the industry as a whole.
Yes, I think, from La Maestra's perspective, we're always looking for additional staff that are interested in growing along with the organization. We've always remained a real grassroots community organization responsive to the needs. Well, that's also people that live within those communities, and what an economic development opportunity to hire from within the communities and help them access the training and grow along with us. Many of our staff have been with us for numerous years. We have always new people joining, and it's a great way to be there. Like at the beginning of telehealth, or the beginning of our RPM program, or AI, and then it's like, wow, we've grown so much, and we've been able to contribute, and we see how our contribution has helped really not only the needs of the organization, but contributed to the health and well-being of the patients. So anything to do with, IT, health, informatics, anything to do with, the network, the cyber security, integration, connectivity. There's still issues connecting, let's say, our pharmacies that we run with the EHR. Dental has Dentrix. It's not in next gen. There's still, as far as so much advancement has been made, but there's still these really basic connections that need to happen. So it has to be somebody who really, really is passionate about being able to really streamline all the systems that we have. And, that's what I'm always looking for. And I think other organizations are as well. It's not just us that face these challenges with these different systems that are industry specific, right?
Right. Very, very well. And this is an interesting point and a valid point to wrap up our conversation, because this fragmentation in various systems that the healthcare organizations and other organizations are facing is a challenge to be yet to be conquered. Well,
Sure.
thank you very much, Zara, again, and best of luck to you and La Maestra.
Thank you so much, Farhad, and thank you, students. Hope you enjoyed it.
Thank you.
Okay, bye-bye.